Thank you, Ellen, and welcome everybody to this Thursday Musing 19th edition on early intervention in ASD. And over to the next slide. Not to waste time, I would just briefly introduce Dr. Amrit Patajoshi as a professor of psychiatry in Bhubaneswar, and he's a direct council member of IPS, and he had been the editor of Odisha Journal of Psychiatry. Next, please. And Dr. Alim Siddiqui is a professor of psychiatry in Iras Lucknow Medical College, and he is currently the honorary treasurer of IPS. And next slide, please. They are the vibrant editors and the vibrant moderators of this program. Now I have the privilege to introduce Dr. Abhijit Fay from Nagpur, our chairperson today, assistant professor at NKPSIMS, consultant National Cancer Institute, and practicing psychiatrist. He has more than 35 publications in national and international journals, contributed in various IPS published books, 4 book chapters. He had been the chairman of Website Committee IPS General Branch from 2014 to 20. He has been the chairman of Website Committee of IPS from 17 to 19. He is the chairman of Telepsychiatry Subcommittee 21 to 23 is continuing, and is the executive committee member of IPS General Branch from 20 to 23, and is honorary secretary of Psychiatric Society of Nagpur. Welcome, Dr. Abhijit. And next chairperson is none other than Dr. Sonia Pariyal, who is a consultant psychiatrist in Raipur. He did MBBS from Gandhi Medical College, Hyderabad. She did her MD from CIP Ranchi. She is the director of Dhanvantari Hospital, Raipur, Chhattisgarh. The chairperson of IPS Task Force on Perinatal Psychiatry. Past president of Chhattisgarh Psychiatric Society. Past co-chairperson and convener IPS Specialty Section 1, Women Mental Health. Is invited guest faculty at various national and state level CMEs. Actively involved in training of health supervisors of State Department of Child and Women Development at Chhattisgarh. She has received the awards Naika Most Popular Women Doctor in Raipur 2010 and Ojaswini Outstanding Lady of the Field of Medicine in Chhattisgarh 2017. Welcome, Dr. Sonia. Welcome, Dr. Fay. From now onwards, as belongs to you, and the CV of Dr. Jigyansa Nayak, our speaker, will be displayed. And please take over.
Thank you, sir. So, am I audible? Am I audible, sir?
Yes, sir, you are.
Yes, sir.
Good evening, all of you. In this 93rd super hit series of academic sessions that is Thursday Musing.
Volume is a little less. To me or everyone, I don't know.
Sir, now it is okay?
Now it is okay because I have removed. Okay, it's okay. Please proceed.
So today's topic is early interventions in autism spectrum disorders, especially the role of psychiatrists or a mental health professional. To introduce this topic, I would say with increasing prevalence, we all come across the patients of ASD, whether it's a child or the adult. And we must have seen that most of the time there is a bit delay in the time they take our consultation. This can be because of maybe parents usually are unaware about the illness, or they think that the symptoms of autism, whether it's an aberrant communication or social skills, or the restricted pattern of behavior as a normal variation of the development, and they wait to them to subside by itself. And when they find it significant, especially when the child goes to school or the preschool, at that time they seek the help. Secondly, many parents take their children first to the either pediatrician or the ENT specialist, or sometimes the counselor or speech therapist. There the assessment starts. Screening happens, and somewhere the diagnosis of autism or autism spectrum disorder is done, and the intervention then starts. And if the behavioral symptoms are prominent, for example, self-destructive behavior or impulsivity, then the role of mental health professionals is really come into picture. And what I would say is, even when there is a role of the role of psychotropic medications is very little, but instead in psychotropic medications can help in reducing the symptoms to the extent that parental distress can be reduced and the cooperativeness of a child can be increased in any therapeutic intervention. And in overall autism spectrum disorder, it is said that early intervention is a key for optimal improvement or optimal outcome. And whether it's in the form of a social skill training, occupational therapy, or even family therapy or sustaining the psychotropic medication. So to discuss about this topic, we have with us today and eminent and dynamic psychiatrist Dr. Jigyasa Sita Patnaik, who has done undergraduation from Utkal University with a gold medal. She is MD and EMD psychiatry. She has worked as a senior resident in AIMS Bhubaneswar. She has received a postdoctorate fellowship in child psychiatry from St. John's, Bangalore. She is currently working as an assistant professor in Department of Psychiatry, Kalinga Institute of Medical Sciences, KIT University, Bhubaneswar. She has been an executive committee member of IPS in 2021-22. She is convener of Social Media Specialty Section of Indian Psychiatric Society, executive body member of IPS Odisha State Branch, and chairman Child Psychiatry Subcommittee of IPS Odisha State Branch. She has received various awards and achievements, including late G.C. Boral Award in 2018, Professor M.C. Mishra Memorial Award in IMECON Odisha 2020. She has more than over 20 publications and more than 70 citations. She is also a recipient of international funding grant by the University of Pittsburgh in 2021. And she also received the Young Psychiatrist Award of Indian Psychiatric Society in 2022. So I hope everyone will get a newer insight into this topic today. So I invite Dr. Jigyasa Sita Patnaik to start her session. Thank you.
Sonia ma'am, would you like to say a few words? Sonia ma'am is there?
Sonia madam. Sonia ma'am is there.
I think she's reconnecting.
They had discussed the chairperson and Dr. Sonia Parel had told that she will give the last comments.
She said that she will conclude at the end.
Hello, am I audible?
Yes, ma'am.
Yeah, ma'am. Yeah.
Yes, I couldn't hear you, Abhijit. Sorry, I missed hearing you. But then I think it's a very interesting topic that we have chosen, because as you rightly pointed out, that autism is missed early in diagnosis, and we need to identify and intervene much earlier, because previously we were diagnosing it not before 4 to 5 years of age. But in the West, they are able to diagnose by age of 2 to 2.5 years by using more standard diagnostic instruments. So, we need to update ourselves and intervene early, because we know that the brain's neuroplasticity is the best in the first 3 years. So if we can identify early and intervene early, we would be improving the long-term outcome of this disorder, which is so much needed because it is spanning across the entire lifespan of the individual. And patients in our clinics are presenting at different times, So studying the developmental milestones, we each need to be aware and how autism can present itself. It's a very, very heterogeneous disorder. So we need to be alert at all stages of life. And Tufan sir for choosing such an interesting topic. And I hope our speaker will be able to do justice to us and we all can learn from her. So I hand over quickly to the speaker, Dr. Jigyasa Ipsita. Welcome to you. And we look forward to an interesting conversation with you in today's live CME with so many participants. Welcome all.
Thank you, ma'am, and thank you, sir. I'm really humbled by such a brilliant introduction. And first of all, I'd like to thank the Thursday Musings for providing me with this opportunity, Dr. Amrit and Dr. Ali and Tofan Pati, sir, for this opportunity. And the topic that is allotted is autism spectrum disorder. And as rightly pointed out by our chairpersons, I would like to request the host to allow me to share the screen. Yes. Thank you. So, as rightly narrated by our esteemed chairpersons and our extremely learned colleagues, what I would like to start with is autism is something which is a heterogeneous disorder. It's something that causes almost a lifetime impact, not just on the person who is suffering from this particular spectrum, but also on the caregivers and the society as a whole. So earlier, the problem was the diagnosis was happening late and people were not very aware. But over the last few years, I think that's a paradigm shift which has occurred because the pediatricians have taken a great initiative. And what they have started doing is they have tried to pick up all the early developmental milestones. And as a part of the RBSK, that is the Rashtriya Bal Swasthya Karyakram, which is there. And because of intensive monitoring by this particular group of pediatricians across all sets of healthcare institutions that are available, people have started picking up autism quite early. And thanks to COVID, I don't know if it's something that is interesting, is something that is good, or maybe a side effect of COVID, because parents stayed at home for a really long time. In the last 2 years that I'm seeing, and that I was working at St. John's, we have started picking up autism really early, like around 1.5 years and even 11 months, as early as even 10 to 11 months, that children and their parents come with symptoms of the child is not having eye contact, the child is not having a social smile, babbling has not started. And these are the kind of symptoms that parents bring us. And the awareness which is there regarding autism and autism spectrum disorder has actually gone into some depth. So that is the first thing I would say, current status regarding the awareness of autism. It is improving. Obviously, there's much to do and there's a long way to go. At the same time, what's challenging for us as mental health professionals, as rightly pointed out, we'll first visit either the pediatricians or the developmental specialists and the ENT specialists and the speech therapist. And what happens is they try to manage it at their level. And a very difficult thing which people usually say is, with time, it gets better. Like you don't have to worry, maybe provide some time. And this kind of maybe some delay which occurs in providing early intervention is something that we can consider as something to worry about. So what's happening? The current status is when someone suspects that it is autism, like there is early developmental speech delay, there's some lack of social communication, lack of reciprocity. What I mean by this is when we really start knowing that this is autism, and the pediatricians, they start noticing that there's something wrong with this child. There's this business of this is not my job, like maybe I should refer to a psychiatrist, refer to a speech therapist, refer to an occupational therapist, and my job is done. And even when they come to a mental health professional, and we as psychiatrists also have very limited exposure during our postgraduate training regarding what to do exactly when a child with autism comes to us. What we do is we know about the criteria that we have for autism. And maybe the earlier criteria stated that before 3 years of age, we cannot diagnose autism. So this is a very big and important limitation in the child's approach to receiving early intervention. So when this is the case and people, our fellow colleagues, and even we, sometimes because of lack of time or whatever reason, or maybe a lack of the confidence that we have within about how to handle the situation, we try to refer here and there. But what needs to be done, and the ideal scenario, is having an early intervention center where all these form of therapies exist, like a speech therapist, an occupational therapist, a special educator, a psychologist, a developmental pediatrician, or a neurologist, and the entire care is provided under one roof. So yes, this is the ideal situation, and in the West, such kind of centers do exist. But we work in India, and the need and where we stand today, there's a significant treatment gap. So in this scenario, when there's a lot of time there to have proper early intervention centers in place, are we qualified enough, or do we have enough information to deal with a child with autism spectrum disorder? And today, after this session, what I hope, like those who are attending the session, maybe at least we go back with a message that if a child comes with autism, what can you as a mental health professional do, maybe in the first visit at least? So this will be what I thought the topic of the presentation and the overview will contain. So what I thought the learning objectives will be, like there's a child with autism spectrum disorder that comes to you in the OPD, and you as a mental health professional, definitely the following issues come in our mind, like diagnostic issues. Is it really autism, or is it just hereditary speech delay, or is it expressive communication disorder, or is it a global developmental delay, or is it just hyperactivity, ADHD, not paying attention, or is it a hearing impairment? So these are the various diagnostic issues that as a mental health professional, we need to be aware of. And then how to assess and how to talk to the parents about what the assessment reveals. The third is initiating early intervention for the child. I'll talk in brief about the pharmacotherapy role, how to handle the common parental concerns and the burden, and then long-term support. At the same time, not just as a mental health professional, but all of us are responsible citizens as well. So briefly, I'll also talk about the social activists inside us. Do we have any responsibility towards these children who are on the spectrum? And this is what my topic will cover. So we start with the first objective is diagnostic issues in autism. So because we are talking of early intervention in autism, the key to early intervention is early diagnosis. So it's very important to know what's the typical developmental milestone trajectory in the child who is typical or with a typical development. So as we see that there's a differential speech delay which occurs. Like for example, a child might be able to walk, talk, and do all the gross motor and fine motor activities, be actually intelligent enough to go and run about and maybe catch up things faster than others. But at the same time, there's a speech delay. There's a lack of response to name call. Like the parents keep calling the name multiple times and the child may respond once. There may be fleeting eye contact. So these are the subtle signs which can be noticed even before 1 year of age, that is even before 12 months. By the time it is 18 months, the other features start becoming very prominent, that they may not have waving bye-bye, talking of bisyllable words, enjoying games, enjoying solitary play. And thanks to COVID, what has happened is over the last 2 years, even children who had typical development in the early ages were confined indoors, and a lot of them had significant regression of milestones, particularly in the domains of speech and language. So in such situations, it is important to know the milestones, gross motor, fine motor, speech, language, and communication, and to notice that if there is a difference between the motor milestones and the other milestones, and if there is a definite difference, it indicates it could be autism. At the same time, a child could be having a global developmental delay. And in addition to that, if the motor milestones are a little bit ahead of the speech and communication milestones, this could also be an indicator that the child has both like intellectual component and the component of autism. So the DSM-5 criteria states about autism spectrum disorder as having two different sets of problems. The first is impaired communication, social communication, and the second is having a group of restricted and repetitive behaviors. But what happens in children with autism when they come very early, that is less than 3 years or even younger than that, they also have a lot of additional difficulties which are present in children with autism, like having significant sensory issues. In the left, we can see sensitivity to noise. In the same way, the other sensitive issues can be surrounding a particular color or maybe the texture of clothes or maybe preferring a particular type of food. So that is something that sensory issues can be very prominent in the early age. The middle one is the thing that we talk about, savant abilities, that the child is able to copy and imitate whatever you teach. Like, for example, there are a group of children who come even at 2 years, having all the skills of maybe if you provide them alphabets and all, so they'll just have a rote memory and keep reciting all of it, even which a child of 5 years may not be able to do. Sometimes those kind of things happen. And that is because the child has some extraordinary cognitive ability. So that can happen. So, and this is something, it's just a picture where the child will be excessively engaged in a particular type of behavior and the child will learn it inappropriately fast. So these are indicators when the child has a restricted and repetitive area of interest or behavior, and we might need to think it is autism. However, the DSM-5 criteria may not suit us enough to actually diagnose autism less than 3 years. So that is why it is important that the diagnostic issues need to be clarified. And if at all there are certain signs indicating a significant delay in milestones in speech and language domain, we need to have a different criteria for assessment and providing feedback. Like, for example, a child with 18 months come with no eye-to-eye contact and no speech, maybe not even babbling or no bisyllable speech. we need to be worried, right? We just cannot dismiss that the child does not fulfill the criteria for DSM-5 and does not need intervention. So this is something which should not be done. So how to go forward with the assessment of these children? We all know that there is 2 screening tools which are available free of cost. The first one, the screening tool, is the MCHAT, that is the modified checklist for assessment of autism in toddlers. So toddlers means less than 3 years, and that is actually about 30 months. So what we do is we find a child who comes that early. So you can apply an MCHAT and see if the child fulfills the criteria. It's a very short checklist where there's only 20 questions, and you can give it to the parents or you can complete it. And it clearly gives a score of low risk, moderate risk, and high risk for autism. The scores are from 0 to 20. 0 to 2 is no risk, 2 to 4 is mild, 4 to 7 is moderate, more than 8 onwards is high risk of autism. So if it is mild and moderate, we do a repeat MCHAT after a few months. If it still is there in that range, we need to provide early intervention. And if it is in the high risk, we do not need to wait any further. That is the point where you refer the child and think of early intervention for this child. At the same time, if a child fulfills the criteria for high risk for autism, we have this Indian scale for assessment of autism, that is the ISA. This is also freely available, and it provides assessment in various domains. And that will also give us the score for autism, if there is no autism or if there is mild, moderate, and severe forms of autism. This checklist is also around 40 questions. So that is something that we can actually get trained in and start administering to kids who come to us, and we can provide them the assessment, at least the brief assessment for autism. The next important step is what sometimes we forget is whatever we assess, we understand that, but it's very important and extremely important to provide a feedback to the parents. It's not just a feedback that the child has autism or does not have autism. It has to be a detailed feedback regarding the domains in which the child has a problem. No two children with autism have the same profile of development, and definitely the domains signify the level of intervention or the significant amount of therapy that will be required to address that particular domain. So the domains feedback should be provided in terms of the ability of the child in social relationship and reciprocity, the emotional responsiveness, speech and language and communication, behavior patterns, sensory aspects, which is very important here because a significant amount of therapy regarding sensory processing deficits is the sensory integration therapy, which is available and is a base of one of the occupational therapy, which is a mainstay of treatment for such children. Then is cognitive component, and based on this, we provide a feedback about low functioning and high functioning autism, and then provide an overall impression about the child. So this helps the parents understand the strengths and the deficits of the child and take appropriate intervention, because it's extremely important to identify the strengths so that we can build on the deficits using the strengths. So that's about assessment and providing a feedback. Definitely, I did not talk about the detailed assessment profile that is done in the early intervention centers. But yes, this assessment that I talked about, MCHAT and ISA, can be done in an OPD basis, and the feedback can also be provided to the parents. So this is the least that I think a mental health professional can provide, irrespective of their expertise or their maybe comfort in dealing with children with autism. Next, if at all you see a child with autism, because there are very limited child psychiatrists in the country today, the number can be in single digit as of now. So it's very important for you as a mental health professional that, because you have the knowledge of assessing whether the child has features suggestive of autism, it's important for you to take the responsibility of initiating intervention. What I mean by initiating intervention is not that you start providing speech therapy, occupational therapy, and everything at your place directly under your supervision. Not necessarily. But yes, we do have dedicated centers as of now, separately for speech therapy, separately for occupational therapy. And these centers do provide some intervention for children with autism. So it's like something is better than nothing. So at least initiating a referral, referring the child to a dedicated speech therapy center is something that you would really want to do. And that is something which can change the future trajectory of a child. So what is early intervention and why are we talking about it? So I'll talk about the importance of it. When to start early intervention? The answer is earlier the better. Yes. And that means even before you are sure of a diagnosis, it's important that the child starts into early intervention. Like, for example, the speech has to be there. Bisyllable speech by 9 months is the typical age of development. If a child is not having bisyllable speech by maybe around 13 months or 14 months, although it is not extreme delay that we consider a child for autism, but yes, why is the child not having speech? There could be something, some problem the child is facing. It could be understimulation, it could be overexposure to screens, it could be maybe some hearing deficits, it could be anything. So the earlier you intervene, the better is the outcome. So yes, even a diagnosis is not mandatory to initiate early intervention. Second, it does improve outcomes. What I mean by outcomes, I'll be discussing in detail. And why is it important to initiate the intervention early? As Sonia ma'am rightly mentioned, that before 3 years of age, the ability of the brain to change, to learn anything is the maximum. And the critical age, like after 5 to 6 years, even if you provide the intervention which is required for the child, the outcome may not be that significant. I'll be talking very briefly about the evidence for the same. So it's important to start providing early intervention because the neuroplasticity of the brain, if at all there's a problem in a particular area of the brain which is not processing information effectively the way we want it to, the surrounding areas of the brain can actually learn and help this particular part learn it effectively if it is done early. But subsequently, the functions of each part of the brain that gets crystallized and they're not able to be plastic to more new information. That is why it is important to provide the earliest as possible. It does improve skills, learning abilities, long-term retention in schools, which is a very significant outcome goal that we want, social integration and lasting relationships. So what is this early intervention and what does it mean? The following are the components of it. The first is a very important school of thought is the applied behavior analysis. So what I'll do is I'll play a brief video talking about one of the principles of ABA, which can be demonstrated to a parent who comes with a child on the spectrum, and they can at least provide them the base on which they can communicate with the child and start communicating. So applied behavior analysis is, I'll give a brief video about it. Then we'll talk about OT and speech therapy. Next is behavior therapy. And last and the most important is the PCIT. PCIT is the parent-child interaction time and therapy. So point 1 and point 4, these are the two things that I'll be focusing on this session, so that this is what the mental health professional or the psychiatrist can spend 20 to 30 minutes explaining to the parent regarding what they can do with the child, right? So if we come here, what is ABA? ABA is, instead of going into the theoretical details, what I'll say is it is using behavior and providing behavioral school of thought techniques to help the child learn. Like, for example, the basic technique is the child does not pay attention, right? So how do we get attention? We use the techniques of positive and negative reinforcement. And that is the basis on which we provide a child a feedback that the child is doing correct or what is desirable. Like the different steps is, like, first technique that I'll talk about is the discrete trial method. So what happens here? There are 3 steps. Like, for example, we're talking to a child. It has to happen in a very clear, consistent, and non-ambiguous manner. So what I mean by that is, the first part of it that you can see here is the SD, or the discriminatory stimulus. Like right now I'm talking a lot of things in the background, right? And then suppose I want to call the child and have a conversation with the child. So what I need to do is I need to cut off all this noise. All of this that we talk like this is noise for the child. That is what we have to understand and know. That's it. If we want to talk to the child, the first is providing a discriminatory stimulus, like name of the child. Suppose we call here maybe John. So John or Johnny or Ram whatever, Ram. And then the person, the child with autism, looks into the eye or pays some attention. So after that, we provide whatever we want the child to do, like maybe a hi, or maybe a smile, or maybe ask a question, whatever we want. So for example, we call the name of the child Rama, like Ram, and then the child pays attention. So the first thing is getting the child's attention. So once the child pays attention, what we do is provide a reinforcement because the child gave a desirable response. The child looked at you once you called. So then maybe you can provide a positive reinforcement. It can be in the form of very good, like we encourage parents to be very loud and clear about giving a positive feedback about very good, and then clapping, and then hugging the child and providing a small maybe play item for some time, very good, and then they give a play item that the child likes. So the reinforcement can be very small, but it has to be consistent, and every time the child gives a positive response. So this is about eye contact or providing a response to name call. So if we proceed earlier, like ahead, suppose we want a child to do something, like maybe imitate us by a bye or a hi, or maybe a high five. So what we do here, we call the name of the child and then say hi. So once the child is not able to do a hi, we take the hand of the child and do a waving in front of the child. Then the child copies it and imitates it. And then even with the prompt, if a child is able to do it, we provide the same reinforcement. Every time we ask the same thing, like for example, the name of the child, Ram, and then a hi, and the child does a hi, and we provide the reinforcement. So this is done till the child responds to our command consistently every time. We usually fix one activity to learn in a week. This is the basic technique of applied behavior analysis. I'll play this brief video. This is a training video which I got from the web. So,
starting with the SD. Though generally an oral instruction, an SD can also be nonverbal, such as a picture, a toy like Mr. Potato Head placed on a table, or the sight of a swing.
You are super!
A good SD must follow several guidelines in order to be effective. First,
yes, so what they're talking about is the SD, that is the discriminatory stimulus, which arouses the attention of the child. So there are different things that have to be there for a SD to be proper. And what they say,
all SDs should be clear and consistent. They should be free of extraneous information. And finally, they should be delivered in a voice slightly louder than a normal speaking tone. Now we will demonstrate what a good SD looks and sounds like.
Do this. Way to go! Wonderful!
right? So what we saw here, we did arouse the attention of the child by the clap, and then do this is a very short and specific instruction. There is no extraordinary distraction around, and then we do it and the child does it, and immediately the reinforcement is provided. So this is the basic technique of ABA, and this technique can be applied across the different domains that I talked about, right? I'll take questions definitely towards the end of the presentation.
Starting with the SD.
Right. So why do we use and why do we train parents in this particular technique is because there are multiple parents who come and say that, like the entire day I spend with the child, but I don't know what to do. The child does not listen to me. So this is what is important, is to help the parent understand how to start this particular form of therapy, or start doing the PCIT, just the parent-child interaction therapy. What we call it is called the floor time concept. Like we arrange a floor usually, which is free of distractions. And usually we set a time of 20 minutes, like one session for 20 minutes. And then we allow the child to be free and move around. And then again, another session for another 20 minutes. So this is how we have a structure for float time play. So for example, we have to have a particular place. It is important to ask your parents to videotape the initial sessions so that if they come back to you, you know what they are doing and what they are not. And if there is something grossly wrong there, like for example, the child is there and the mother immediately enters without letting the child be comfortable, then the child may not be cooperative enough to do any sort of therapy. So a few techniques are there. Is first, when you start a session, it's important to leave the child alone, allow him or her to explore what's going on. And then once the child has started exploring, join in with the child and interact with the child in whatever he or she is doing. It's important to be patient. And this is how we can just have a brief start to whatever is there. This is bridging the gap till the time you find a proper intervention specialist for a child, and maybe have a special educator in place, because every day counts. It's just 5 years of like 1500 days of one's life. And by the time they come to you, half of it is already gone. So it's a matter of another 200 days only. So every day counts and every minute of intervention helps. So that is why it's important to have parent-child interaction therapy start on the first day itself, so that the mother or the father learns to pay attention to the child. So next, coming to the principle of sensory integration and what is done here. So this is important because a lot of occupational therapy centers, they actually do a lot of sensory integration activities. So what they do and why as a psychiatrist, we need to refer the child to a sensory integration therapist or occupational therapist is because we learn by 5 senses, like the sight, the hearing, the smell, and the taste, and most importantly, the touch. But in addition, children with autism, it's important to mention 2 other senses. One is the vestibular sense and the other is the kinesthetic sense. What I mean by vestibular and kinesthetic is because a lot of hyperactivity or hypoactivity is because of sensory processing deficits, primarily affecting these 2 domains. So what we see here and what the kind of therapy we do is we actually provide a child with a lot of kinesthetic activities. If the child has sensory processing deficits in that area, they provide a lot of movement-based activities. You must have seen in the OT rooms, they try to swing the child. There's a big ball on which the child is allowed to lay down and come up. It's because it stimulates the vestibular senses and the kinesthetic senses. So this is basically the principle of sensory integration, so that you can explain it to the parents regarding the need for it. And why does someone, because parents will come and tell you, like the ball, in the ball, they're playing something and that looks weird, like my child does not need that. So it's important for you to explain them how it works and the particular role of sensory integration therapies. So before the sensory therapists start this particular thing, they do a good assessment and accordingly they provide the therapies. Second, this is behavior therapy. This can be done by a psychologist if you have at your center. It can be done, and it works on all the basic principles of normal behavior therapy, like providing a positive reinforcement, a negative reinforcement, and all that. And the most important indication for behavior therapy usually is having some restricted repetitive behaviors or one behavior which keeps on occurring repeatedly. So what is seen as children which we have a particular stereotype movement. It can be a hand movement, a hand flapping movement, nodding movements, squirming movements, jumping, whatever kind of activity it is. It is seen that certain situations do exaggerate this activity. It can be in response to anxiety situations, and this is possibly a way of coping for children with autism because they do not have any other mechanism of coping. Suppose a child is provided with a lot of sensory stimulation, like here, for example, and the child is overloaded. So this kind of restricted repetitive behavior keeps on happening. But if we are able to find a narrowing down of the sensory stimulus, like providing a headphone or the bright lights are there, provide a specs, black goggles, this kind of behavior subsides. But all sorts of behavior, this happens. It initially comes as a habit. If at the right point of time, we provide the right intervention, the habits do not become a constant repetitive behavior. And that is the purpose of early intervention. Like for this example here, this particular child had a lot of stereotypes and restricted interest with having the strains and watching their timings and keeping a schedule of that. So what we can do is, it is not actually important that you stop the child completely from doing that restrictive behavior, but instead provide a structure for the same. Like what you can ask the parents to do, like suppose the child wants to go to the railway station every time. So what you can do is, okay, I'll take you, but there's this particular time that when I'll take you, or maybe for 20 minutes we can go and then we have to come back. So the entire purpose of behavior therapy's role is providing a structure to the child so that the child knows what is desirable and what is not, providing interventions, and then including the restricted and repetitive behaviors, so that if at all we provide a structure, maybe it can be as beautiful as this young child has drawn this beautiful drawing, where a series of only making lines and like that is the only thing that she is doing. But if you make a structure and provide a decor for the same, it turns out to be something which is truly magical. This is what behavior therapy talks about. So yes, all of this does sound good, but does it work? And how do we know it? So there are multiple studies which are done. This is the University of Washington study. I'll just highlight one finding here. Intervention which was provided before the age of 5 years versus those intervention was provided after 5 years, was seen a significant number of children become verbal, and non-verbal children reduce significantly. And if we say, if that's for the West, do we have any data for India? Yes, there's a similar kind of intervention which is indigenously developed by one of the pioneers in South India, and she's Dr. Pratibha Karant. And she's actually developed this COMDEAL module, which is there for early intervention in India. And she's actually working on this, and she's already established 22 centers for same. I'm talking about this particular mode of intervention because I'm trained in that. There may be other forms of therapy which are there, but this is the only indigenous-based intervention which is effective and has a lot of evidence for it as well. So if we say early intervention works, yes, it does. And if we conclude regarding this early intervention part, what kind of message should go from a psychiatrist to a parent? The first is early intervention is the key. Second, autism is not a tragedy and things can be much better with proper intervention. So that's about initiating early intervention for the child and providing a feedback to the parent. Next, coming to the role of pharmacotherapy. So this is the domain that all psychiatrists, all of us are very maybe comfortable in writing prescriptions for such children because they seem to be very hyperactive, always disturbed, not paying attention. So it's important to understand a lot of comorbidities do exist with autism. And a very common comorbidity is anxiety, in addition to the other neurodevelopmental disorders. Restricted repetitive behavior can be mistaken as ADHD. Even an anxiety can provoke a stereotype, which can be mistaken as maybe a defiant behavior or a tantrum and things like that. Having said all that, it's important to know that the role of pharmacotherapy for the core symptoms of autism is limited. Having said this, does that mean we don't write any medications? No, medications do have a role. And the indications for which we can use medications are highlighted here. Like, for example, sleep cycle is grossly distorted. Then maybe regularization of the cycle can be done by melatonin. This is a very safe, effective, no side effect drug, and it works miraculously well for children on the spectrum. Secondly, we need to look for anxiety and depression, and there's a role of SSRIs there. Agitation, aggression, yes, low dose antipsychotics, risperidone and aripiprazole have the best evidence. Autism with tics, we provide antipsychotics. Self-harm behavior, in addition to the antipsychotics, we have naltrexone. If there is comorbid ADHD, if it is with tics, we can choose acamprosate, without tics, with haloperidol. And definitely we need to choose medications for the seizures. With this particular overview that we have, the list of comorbidities, it is extremely important to note that the anxiety or the depression or any sort of ADHD in a child with autism does not present in the typical way RDSM or ICD talk about. There is a gross deviation in the way this presents with such children. And as of now, we do not have any standardized tool to assess the same in children on the spectrum. So for now, maybe what we can do is have our eyes open so that we're not missing any of these for just the stereotyping. Right? So coming to the next, but the most important part of it is handling the parental concerns and the burden. So these are the few common parental concerns I'll say, like after you talk to the child, talk to the parents, provide them everything, they come with a question like, why me? Like, it's not, all of this happened, but why me? Who's at fault? Is it because the father did not give time? Because I said it was 6 months and the child is not babbling, did not pay me time. Or the father says, you went to work early and that is why this happened. So there's this blame game which keeps on going on in the family. Then they also start having this, what could I have done to prevent it? And then there's a guilt trip, like maybe I could have done this. And then a very common presentation among parents is they come with depression or severe anxiety. The next question that they have, okay, this child is maybe on the spectrum. What about the next child? I think if I have a next child, maybe that child will play with this child and things will be fine. So this is the question that we have to address. And the answer to this, I'll give it very clear and very straight. It's that the risk for the next sibling to be on the spectrum is less than 30%, less than a third. That's some positive option, but there's no guarantee that the child will have autism or not. So it's completely an informed decision that the parents have to take. There was this concept of refrigerator mother some time back, which had an immense stigma and impact on the mother's mental health. For now, it's for all practical purposes, this concept of refrigerator mother is not valid. So we do not believe in that concept that a child is on the spectrum because the mother is emotionally not that rich. So this is not valid. So do not try to, maybe even make this comment. And even they talk about it, it's important for the psychiatrist to neutralize it and say, no, it's not. Another question, the mothers usually they come, like, should I leave my job and I give my full time to the child? The answer for this is difficult. And I don't have a uniform answer for this, but maybe considering the age of the child, we can provide her with some advice, because if it is less than 5 years, definitely providing early intervention will make a definite impact on the long-term trajectory. But if leaving a job is like a permanent thing or a temporary thing, these are things that we can discuss. Maybe 2 to 3 months, some mother can take a break from job and then provide intervention to the child. The child gets better, goes back to the mainstream, then maybe the mother can join back. So it's very important to have various options discussed. And these days, the workplace and a lot of IT sector and those kind of institutions are very open. If a psychiatrist can make a call and talk to the employer, this does make a difference. And then the last question, will the child be ever normal again? So here it's important to understand, why does the child have to be normal? That's the question. So a few years back, we had this concept that the earth is flat and no one even questioned it. But the earth turned out to be round. And after evidence was there for the earth to be round, people started thinking, how foolish were we? Similarly, it could be a fact that today what we see as autism is a disorder and autism is a problem. It's abnormal. Maybe it's just a different way of the brain developing. So maybe we can leave the parents with this note that we're not sure what normal is, but yes, this is a different way of development of the brain. We don't know if it's normal or completely abnormal. Yeah, it's atypical, but that does not have to be, or does not mean that it's abnormal. And this is one thing that I always want to share with the young budding psychiatrists is it's not that the children with autism have a problem with communication. This particular hypothesis, the double empathy problem, says that it's that autistic children or people with autism communicate very well with people with autism, and people with non-autism, they communicate well with people with non-autism. However, when they try to interact with each other, there's a problem. So I'll talk about this particular study. This is a very interesting study, what happened in Edinburgh. This common game of Chinese whispers, where we know there's a chain in the top right, you can see there's this chain of green, who are children with autism, and that is one group. The second chain, which is red, it is the group with non-autism. And then the last is the mixed chain, where there are alternate autism and non-autism persons who are standing. And then they start playing this Chinese whispers, where in 1 year, you say something, and then the person is supposed to whisper in each of these ears, and the information is supposed to travel. And the last person says what the first person has heard. So here it was seen that on the left, this graph, if you see, in the only autism group and in the only non-autism group, the level of error was similar. However, in the mixed group, there was a significant increase in the amount of errors and significant communication deficit was seen. So this means that it may not be that children with autism only have a problem. It's a bidirectional problem. We don't understand them and they don't understand us. Similarly, if we provide, I always try to show the parents who come to me this particular picture. Like, for example, on the left, you see a regular classroom where it's very chaotic, a lot of noise. We don't know what's happening. Even when we see it at a point, it looks chaotic to us as well. However, what children with autism need is definite structure and places. So if we can provide a child a school like on the right, or maybe at least a similar setting at home, then a child may not be more disabled with autism. So this is what we can tell them to the parents, help them understand autism and the child, tell them abnormal child may not be the right word, but maybe it could be that a child on the spectrum is what they can say. And it's very important to emphasize it's not their fault. At the same time, they ask us questions, like, what is the capacity of my child? What do I expect of this child? Where will this child go in future? It's important to be honest. Say if you don't know, say that, yes, I don't know. I'll need to have further assessments for the same. Maybe I'll refer you to some place which is better or worse, and maybe then only you'll be able to give an answer. So here it's important to be honest. Say if you don't know, yes, I don't know. Say if it can be anything. It can, like this is the percentage or statistics. And that is important because the parents need to have the realistic view and not anything which is here and there. At the same time, like maybe in the early part, they talk about early intervention, but what about long term? The challenges across lifespan vary. In childhood, maybe the problems that we talked about are primary, but as they grow, and if at all early intervention happens, a lot of subtle communication deficits persist. So they may have long-term issues with having peers, establishing romantic relationships, have problems with marriage, love, employment issues, because teamwork and those kind of things may be difficult. So it's important to address these challenges as the child grows up as well. Last but not the least, it's important to say that your role does not just end in the clinic. It's important to create a world where a child with autism has some support, and at least you can be a mentor there. Why should we worry? Because this is the statistics from USA. We do not have similar data from India, but definitely with the number of children visiting, I would say I work at a very small place, but every day in the clinic, I see at least 1 or 2 children with autism. Like that's the significance and the burden of autism today. I'm really sad and I'm really worried about the future of the country as well, because I know definitely all mental health professionals will be dealing with the same scenario. Some acknowledge it, some do not know what to do. A lot actually understand it's a problem, but we are helpless and we feel limited by the resources that we have. So it's important to develop a society where people start advocating for autism, to start having the left side, we have a deficit model of autism where there is a lot of deficits with the child, executive function deficits, information processing deficits, repetitive behaviors, which are a problem. And from there, we help the child to deal with all of this and then come over to a concept where maybe the child is not abnormal and a liability on the society, but rather can become an asset. So the process for that would be maybe a paradigm shift is needed in the way we think about autism. Like, for example, if we see that everything, the problem is with the child has a diagnosis, the child is deficient, child is abnormal, the child is maybe mentally broken and insane, the entire liability lies on the child. But if we try to take some responsibility and start providing alternative modes of communication, right? The first thing. Second is there's a lot of technological advancement today where even, like just pressing a button can deliver the amount of the need of whatever the child wants to say. Similarly, organizational changes, as I mentioned, the structured classroom is very important. At the same time, having an attitudinal change, like if a child is on the spectrum, it's important not to bully the child and to be inclusive and provide an environment that the child feels accepted. So this will, in the overall scenario, possibly improve the well-being of the child and the society as well, because we do not know how many children with autism we are going to face in the near future. So it's important to move from the medical model to the social model. So individual deficits to maybe identifying the societal barriers as well. The stigma and discrimination that such children and parents face, not just children, it is also the parents. Like suppose a child with autism goes and starts playing. Other parents say that don't go, like maybe as if it is contagious and stuff like that. We were talking about the like suppose a child is autistic. The parents used to lock up their children in a room, like because other people will feel offended. What will my child do there? So instead of seclusion and thinking about special schools, today the right of all children with autism is inclusion. Inclusion not just at education level, but also at employment. And it's important to see the child as a different way of development as well, and not just a child with autism. So summarizing all of it, I think these are the various objectives I did cover, and I'm open for questions. Maybe it's over to the chairpersons.
Thank you so much, Jigyasa. A really wonderful presentation. Over to chairpersons for any opening comments.
Sonia madam, you are muted. Please unmute yourself, madam.
Am I audible now?
Yes, madam.
Very well organized presentation, so nicely depicted the practical issues that we all face as psychiatrists, at how to intervene and when to intervene. I think to begin with, what's very important after listening to you was that to give the hope to the patients that and the clients, parents, that yes, there are interventions that can be done. I think in routine clinical practice as practitioners, we always tell our parents, don't get overwhelmed by the word autism. This word itself creates so much anxiety in parents. In fact, I practically always tell there is some developmental delay, and let's be hopeful. And the earlier we intervene, the better it is. So, having a multimodal approach, like you very rightly pointed out, we don't have centers where speech therapy is there at the same center. Are we having the hearing impairment assist early? So now we, in a small city like Raipur, I do have a pediatrician who's trying to provide all these services under one roof, and he does interact with us. So I think the psychiatrist, the pediatrician, and the other therapists, when you do a multimodal approach, it definitely helps. But Jigyasa, what is your own, I think all of us face this issue about the scales that you said, the MChat and the ISAY. I must say the Hindi version is also available on the net free of cost. But many a times the practical issue is our clients are not so educated, the parents, to even understand those words properly. So many a times I ask my psychologist that when you are administering this, please be there to clarify and explain. So I still feel there's a lot of scope in improving those assessment scales from the Indian point of view. I'd like to hear your opinion on that as well.
Yes, ma'am. Ma'am rightly pointed out, given to the parents, it is very difficult to understand because there are a lot of technical terminologies which are also involved. However, ma'am, for ESA, it was particularly developed for the Indian scenario, as far as I know. And the initial training for trainers was also provided. So it is primarily for us or professionals to provide the assessment and actually do the assessment. And it is not usually for the parents to do it. For educated people, maybe the MChat is something that I give it to them. But ESA, ma'am, is something that it's only us that we have to do it.
Thank you, Jess. So another issue I wanted to ask, a lot of female children are missed with autism. We know, of course, there's a 3:1 ratio in the male child. But I think a lot of our females, I mean, there's a theoretical explanation that they camouflage their symptoms, that the presentation of the female child is quite different. Have you had any experiences with children, I mean, females with autism presenting a bit differently compared to their male counterparts?
Yes, ma'am. I do have very limited experience, of course, but the first thing is they're diagnosed pretty late. Like the children that I saw, I think I have two children who are on the spectrum, and the first and the subtle symptoms started developing only at 8 to 9 years of age, when they started maybe having difficulties with peers, remaining a bit excluded. But because they were high functioning, both of them, uh, they were performing really well at school, and supposedly females are supposed to be silent in the Indian culture. So maybe that is another barrier that is there for early presentation of females in particular. And the high functioning children of the females in particular, they also have a very high sense of longing for social belongingness. And they go to any extent to feel that sense of connection. And sometimes they're extremely frustrated and they present to us with depression or suicide attempt or self-harm behavior. So that is the presentation with which I have seen both these children who are there. And I completely agree with you. They might be having a different way of presentation now.
So we keep it for all our so many questions. I think 36. I think Amrit, Alim, would you like to take them individually? In the chat box, we have a.
Yeah, we'll be taking few of the questions. Alim.
Yes, Jigyasa, there is a question saying that this about this fine motor development. So someone pointed out that did you say that fine motor development is good in these children, and whether hugging as a positive reinforcement would be good for everyone?
Generalizing anything that I said, I think that cannot be done. It has to be specific to a particular child and has to be tailored. What I said was an example, which maybe parents can take it, and maybe all the psychiatrists who are present here can understand. This is one of the mechanisms which work for some children, but definitely hugging for children who have a lot of tactile sensitivity may not work well. So in those children, maybe we can try for other methods, like maybe providing a small chocolate or providing a toy which they like immediately after the desirable response. That's about the second point. And so what was the first question regarding?
Someone commented that these
Fine
children
motor.
have good fine motor development.
Yes, sir. So regarding fine motor development, so there's a lot of apraxias which are very commonly seen as comorbidities with autism. So it is mainly coordination, motor coordination problems that are there that might primarily look like as if it is a fine motor issue. But definitely isolating motor, fine motor, language, communication, making it categorical and making a distinguished opinion about it may not be actually needed, because a lot of children usually have comorbid disabilities and difficulties, and it's not just isolated. Gross motor being normal and language being something abnormal is a very easy way of picking it, but that's not the rule. Like maybe that's very rarely actually there. Children usually have comorbidities. More than 30% have global developmental delay, another 30% have seizures. And this developmental apraxia with fine motor deficits, or maybe 60% of children with autism have it.
Thank you. Amrit.
Jigyasa, congratulations for a wonderfully delivered talk. It was very good. So a comment, somebody has given a comment and I wanted your opinion on that. Isn't there an increased diagnosis of ASD in COVID times, including developmental lag, speech delays, islets of sensory sensitivity? Many such cases have improved with less screen, reassurance, and increased parental engagement only. Because we see a lot of people who parents come that somebody has diagnosed us with ASD or autism, and they're all worried. They come, and then we just have to sit with the clients for 10-15 minutes and reassure them that there's nothing wrong. If something is there, come after 1 year. So your comments on the comment given by Bikram Dutt. What is your opinion, take on that?
I would like to divide the answer to this question in two parts, maybe. The first part is increased diagnosis of autism in COVID times. Yes, it has increased, point one. The reasons could be actual increase in like cases with autism spectrum, or maybe early presentation because the parents stayed at home the entire day, or third, maybe increased screen exposure, which has resulted in autistic features. So yes, diagnosis has increased, but labeling or making a diagnosis of ASD before the age of 3 years, we do it with a lot of caution. Actually, we do not say that a child is diagnosed as autism spectrum disorder. We usually say the child is at high risk of autism. The child has autistic features is what we usually say. However, we provide the intervention, and sir, as you must be knowing, the Rutter's classificatory system of multi-axis classification, which is still valid for childhood psychiatry. The fifth axis, the primary point there is understimulation and psychosocial deprivation. Before correcting that, if at all we suspect that there is a significant deprivation or neglect, we first correct that, and then we go for giving an axis one confirmatory diagnosis. So yes, both the points that are raised by Dr. Vikram, I completely agree with it, and thanks for pointing that out, sir.
Jigyansa, what is the dropout rate of the people undergoing therapy, and what is how do you measure the success that you are getting in the clinic, or one should measure it?
So dropout rate in therapy, sir, for autism, the particular therapy that needs to be done, I don't think I provide it accurately. What I do is I do some specs of maybe ABA orientation, providing the parents an opportunity for continuing therapy at a dedicated center. So going for a speech therapy and occupational therapy with proper education, they do sustain, because we educate them that at least it's going to take 6 months. 1 or 2 sessions is not going to do anything. So if this is what we talk to the parents, they do sustain for at least 2 to 3 months. And another thing what I do is actually keep a follow-up track. After 1 month, we call them and see if the therapy is actually working, because there's a lot of barriers there as well. Like the centers are usually overcrowded, like there are already other children who are disturbed, and that disturbs this particular child as well. So these are the barriers which are usually there. So if we address those barriers, definitely the compliance to therapy improves. Or if one center does not suit, the common reasons are, I don't have a center near my home. The second is long-term feasibility. I cannot give that much time. There's a lot of waiting time that's there. Traveling from one therapy center, speech therapy to occupational therapy, takes a lot of time and exertion because the child is on the spectrum. There's a lot of difficulty. So these are the usual barriers. And if we address each of it individually, talk to the parents, then maybe we can go a long run, sir. But because primarily I do not do therapy for autism, it's difficult to comment on the retention rate or the dropout rate. But yes, the children that I follow up, they do come to me. So I think that's something that is sustained. At least they see a doctor. So maybe that is the important role we as a psychiatrist can play in helping them establish compliance to therapies.
So in relation to this, Nitya has asked a question. A common question by parents is, at what point do we stop therapy or interventions, and how to answer this?
So this is a very nice question that is taken up, because assessment is not a one-time thing. It's a continuous assessment that keeps occurring, at least at 6 months interval. So the model that I talked about, that is the Comdale intervention model by Dr. Pratibha Karanth, her model says assessment every 3 months to see what is the progress till the time the child is able to achieve the developmentally appropriate domains of development. Right? So till you feel that the child has capacity to develop, we continue therapy. And then when we know that even when providing all adequate measures of intervention, the child is not developing, maybe that is a child who is nonverbal. And then we start providing AACs, alternative communication modalities. And with that, if the child is able to communicate, we stop. The basic aim is to make the child functional, and as per the IQ, achieve its capacity, sir. So it is not that we stop intervention, it's that we change the mode of intervention. After a point of time, they might just need peer support system for social skills and those kind of things. So there is no stopping guidelines as such. I hope I did answer the question, sir.
Dr. Jigyasa, there are some questions regarding diet. Now we see a lot of companies coming with dietary interventions. So there are few questions. I'll just add up every question and ask you. So the question on gut microbe infusion. There's a question on ketogenic diet. And there's a supplementary question on memantine and amino acids. So I thought if you could give your comments on, and a lot of people come with diet specification, diet changes and all.
Yes. This is a very important question. The parents also give it to us, like such and such person recommended this particular diet. And there's a lot of supplements also that are available, including L-carnosine and L-carnitine. But I hope this is not sponsored by a pharma company. So I think I can give my honest evidence-based opinion on this. As of now, all sorts of dietary supplements that are available, including multivitamins, L-carnosine, the gluten-free, casein-free diet, ketogenic diet, and other forms of omega-3 fatty acids or any form of nutritional supplementation has limited evidence so that we write it in our prescription. However, research of all these domains is underway. There is some beneficial reports, anecdotal reports, which are there. So it depends on if at all you diagnose a child with some deficiency, definitely you can. Suppose a child is having maybe epilepsy. So there is a role of ketogenic diet in refractory epilepsy cases, which is a common thing in autism. So maybe there, yes. But routinely, as a blanket statement, I would say that there is limited evidence for that.
Thank you.
Thank you, sir.
There was a question about use of camprosate. What is the dose and at what age it can be given?
So, more than 6 years. Usually, sir, we start prescribing only after 6 years. Before 6 years, I don't personally recommend using any particular ADHD specific treatments, maybe stimulants or non-stimulants. We can start with like 10 mg maybe, and then gradually increase depending on the body weight. Sometimes these children may require more than the dose that is required by a typical population, and we can safely go if there are no side effects and the child is tolerating well.
Yeah, another very important question, and that's a very pertinent question when it comes to practicing child psychiatry. That's the therapeutic nihilism. That's a very, in India, like the resources are very, very scarce. People, many of the autistic children do not belong to metropolitan places where you get most of the services under one roof. People have to, come rent houses, stay for 3 months, 6 months. And the major issue I see in a place like Bhubaneswar is when I was working in Ranchi, we had these places where the parents were also trained. Occupational therapists, they would also train the parents so that they can go back home and train the parents could train the children. But here what I see that whichever places are there, the rehabilitation centers or OT centers, they don't allow the parents to see what is happening. So for poor people, this is very, very, this is a very, very negative way because they don't know what is happening inside. They don't know what to do when they go back home. Because I think that should be a continuous process. Because everybody cannot afford that. And somewhere when you don't get the results, because the efforts which you put in, if you give a risperidone, if you give the results are sometimes very dramatic. So and when it comes to intervention in terms of therapy, in terms of it's very, very taxing. The changes are very, very minimal. It might be minimal for somebody, but it might be maximal for somebody else. So how do you have started your practice? I know you have just started your practice, and it's tough to ask you this question, but I'll just give you a small message I got from an autistic parent. The mother was our librarian in CIP. She died, and her daughter had an autistic child. She wrote, "Maybe bhai, this is a small achievement for rest of the world. But bhai, from the core of my heart as a mother, I'm thankful to you because you have given him a new life." A small change, which I felt was minimal. For the parent, it was a maximum. So sometimes how do you deal with many of the children which will not show improvement? So I think that's an area which you should comment on how you deal with such things.
Yes, sir. So what I would like to say is maybe I would like to change the way I see your questions. Maybe the perspective with you see, as you rightly said, what is small for us, maybe a life for someone else. That's the first point, sir. As you very rightly pointed out, that small message must have given you so much pleasure. Maybe a schizophrenic person going back home, you may not know, like it's almost equivalent to that. So therapeutic nihilism is something that we as psychiatrists should not advocate, is what I feel. Instead of talking about there's lack of therapy centers, there's no early intervention available, I think all of us who are attending this seminar today are capable enough to initiate one center under their supervision and be the team leader. It does not have to be you have a qualification in child psychiatry as such. All psychiatrists are well experienced and trained that they can do it if they have the intention to do that, right? And the only problem is because the speech therapists and occupational therapists are doing it at their own level, maybe the holistic care or the integrated comprehensive care that needs to develop is not developing. So if we want to make a real change, I think all of us can go back and think about starting an early intervention center. There are a lot of centers which provide training, and they will provide you affiliation as well. The model that I'm talking about repeatedly, because this is the ComDeal model, and that has maybe changed the way I see autism today. I was equally nihilistic about child psychiatry and particularly developmental disorders before I had an exposure in ComDeal model. So maybe all of us can actually go back and have a look at the ComDeal model, because Dr. Pratibha Karanth has actually opened 22 centers, and she is willing to train more people across India. And her current area of focus is also in the Eastern India, sir, right now, where there's no centers, including Ranchi, Kolkata, and Bhubaneswar. So maybe if you want, if you really allow me, I can also share the details, and I think we can have a collaborative network where we bridge this gap and actually make this barrier a little bit less for children with autism, and the nihilism changes to something where something can be done, and we have at least something to offer to these children and not just nihilism.
Okay, Jigyasa, can you throw some light on this occupational therapy aspect? How can people set up parts of it, or it has to be referred to a specialist, or can we do it in our own clinics or our small setups?
Yes, sir. I think the dimension, if I start talking about the infrastructure that is required, the dimension of a room can be 10 into 12 centimeter, 12 foot diameter, where we need to have a very few instruments like a big ball, some swings, some ropes, and then a lot of tools as in fine motor, gross motor, and those kind of tools. If you permit me, I'll send across the entire list, and the entire list, if you buy all of it, sir, it will not even cost 40,000 to 50,000. I recently bought a set, sir. That is why I'm able to tell you the exact rate. That is in Odisha. So maybe it will vary 5 to 10,000 across at your place. And it's, I won't say the occupational
That would
therapy.
yeah.
Yes, sir. So you said something?
That would be great if you can send the details.
Yes, sir. I'll do that, sir.
Put it in the chat box if possible. Yes.
Okay, I'll do that as well.
Thank you so much.
Achha, tell me one thing. We were talking about special schools and children admitted in the general normal schools. So, what should a person choose? What is a better way?
So what we talk about here is making the child school ready. That is what we talk about. Our goal is always to make the child go into the mainstream school. If a child is not school ready, definitely we provide special interventions, special education till the time a child is able to go to a normal school. If at all the child is low functioning or maybe requires significant interventions, we have other options about like the NIOS, the open school system, and those kind of things. But if at all the child is able to sit and learn, then facility for inclusive education, like providing a special educator for 2 or 3 children with autism in a class where a normal school is going on, is the model. So there are different models which are also discussed about it, like they can attend the normal school for one class, and the other times in the same school they attend a special class. That is one model which works. Another is they have the online class going on, and there is a special teacher who sits with these children at the back of the class and does one-on-one therapy with them. So these are the different models that are there, but inclusive education is the goal, and that is the right of a child as well.
Okay, Amrit.
I think she has spoken more than enough, and we should give her a break. Maybe we'll call up another session later on. Musings will go on, and we have such young, dynamic people with us. So we'll hand it over to the chairperson. Sonia Madam is all smiles. So let's hear from her.
Unmute, please.
I think
Unmute. We need to mute Ali and unmute you. Yes, unmute again, madam.
Am I audible now?
Yes, madam.
Yes, ma'am.
Okay, thank you so much, Jigyasa, for such a wonderful talk. So much to learn from you today. And I think at the end of it, the message to us is that autism is a heterogeneous disorder. I think now with DSM-5, putting it as autism spectrum disorders. So I think that is the heterogeneity of this group. So our treatment also has to be tailor-made and individualized. And what Alim pointed out that, at what time do you need to stop the treatment? Yes, it's a lifelong process. And I think we should monitor our patients regularly. And like you said, give them that hope. It's so important. So many times we have such a nihilistic approach. The child psychiatry, now patient will improve. It was like generalizing psychiatry. Schizophrenia doesn't improve. Schizophrenia has improved so much. So why not autism? So I'm sure we're going to find out what is the neurobiology behind it, because that's going to be the area of research in the future. And hopefully we'll have some better molecules also addressing it, because of course this is genetic disorder. We know there's no role of parenting as such to be blamed. So whether autism is a subtype of schizophrenia or whether autism, if it's Rett's, Asperger's, it's just a neurodevelopmental disorder. I think people like Bhaskar would enlighten us more later on in one of our sessions, because that's a research where it's going on. Right now, yes, interventions as far as, I was just reading, I would like all of you to go through the psychiatric clinics of North America, who want to really read the topic in a comprehensive manner, December 2020. That's a beautiful review of all aspects of autism, right from diagnosis to treatment to interventions. But Jigyasa, what you rightly pointed out, ma'am, has made 22 centers of training. I think some of us should really be exposed to it. And so that, we get a positive approach. Early interventions are definitely giving us a good feedback. I have 2 centers here in Raipur, a school by name of Akanksha, where it is, providing speech therapy, OT, all kinds of development delay center they have. So they interact with the psychiatrist. I think that I would recommend. If you can't have your center of your own, at least be associated with such centers. And then we give right inputs regarding the role of medications. I really appreciate what Amrit pointed out. Even sometimes low dose risperidone, low dose aripiprazole, the self-harm behaviors, the associated medical comorbidities, you need to address them. You need to treat them early. How you differentiate? Yes, it's a challenge, but I would never say over-medicate, because medications still are not established. But if you have a pharmacological rationale to address those behaviors, you get success. And do encourage what you very rightly pointed out, that they be the parents, the parent-child interaction. A lot of videos are available on YouTube. So why not, make it more culturally acceptable, have it in our languages, I think would help prepare some. So we could all distribute it, in our clinics. And these parents, when they see these videos, they can learn and they can do it at home. COVID has taught us so much of digitalization and interventions. I think every village is also having net facilities these days. So why not give them the access through these videos, so the parents can develop their own skills. Because many parents are very alert, even the rural background, we see they pick up, something is abnormal with my child. Something is odd. And she'll also tell you the strengths of her child. So if we can, tap on her inputs and tailor make it, individualize the plan depending upon the background she's from her, I think that would be the key to helping these children early and giving them better outcomes. Thank you again, Jigyasa. It was lovely listening to you, and such a nice presentation that you made, your slides and everything. We have so much to learn from you. We hope to have you again. I think I would give it to, he's joined in fact. Sorry, I missed the net in your initial presentation. My chair would like to give his final words.
No, everything, yeah, already covered everything, yeah. But just one comment I want to comment on. A very nice presentation, wonderful presentation. It was comprehensive and practically oriented for the clinical practitioner. What ma'am rightly pointed out, as a psychiatrist, we should increase the awareness, increase the screening and the assessment, and we should have good liaison with other specialists so that we can pick up these kids early and start intervention early. That's what I wanted to say. Thank you so much. It was a wonderful presentation. Thank you.
Thank you, Dr. Abhijit. Over to our chairperson, Dr. Tufan sir.
Am I audible?
Yes,
Yes,
audible, visible, your front is also
No,
visible.
my microphone got out of order. I am speaking to the laptop microphone.
Great.
That's charged. Well, Jigyasa, it was a wonderful presentation. I, on behalf of all of us, feel proud of you. Fantastic presentation. But some corollaries are there. The places which have such wonderful people like Jigyasa in all places, all over India there. Why we are not taking initiative to have centers for ASD in the background that ASD incidents in India is almost as in the world is 1 per 1,000. 1 per 1,000 means there are quite a good number of children who need attention. And my 40 years experience tells that in rural areas and even suburban areas, these children are managed, tolerated and not brought forth. So what needs to take place is that we have to have a awareness and I am speaking of another different aspect in collaboration with pediatricians, general practitioners, and if required with other mental health providers, because people take them to those people and they give a very nihilistic opinion. You think of it, nothing will happen, you don't try, you give him good food and they are forgotten. And it's a criminal offense to neglect children to this extent. And we do not treat all of us taken together, around 250 people or 300 people who had been here and who will listen it over Facebook. Sum total, we are not seeing that much of ASD patients. We are seeing those who are privileged enough to come to us because one of us is in Lucknow, one of us in Bhubaneswar, one is in Raipur. And we have to address to the real population who need attention. And because they have to be given something. Being psychiatrist this year state, we are thinking of therapeutic nihilism. Think of a pediatrician, medicine practitioner, how we get needing to see 500 cases a day. They will be in the grip of therapeutic, just ignoring, brushing up this place. So what I need to think, we must have awareness and collaboration with other disciplines to whom the patients really go. Otherwise, dementia, these cases will have the patients need. Nobody cares for them when they come to us after 5 to 7 years of mistreatment, wrong treatment, and emotionally maltreatment. It is sad to see that they are part of a fraternity. This is my sum total opinion, but Jigyas, you are wonderful and you can take lead in Odisha, then in Eastern Zone, and why not in India? And sky is the limit. God bless you.
I'm just beginning my career. Thank you for your blessings and for those wonderful words. Thank you, everyone, for the opportunity.
Thank you, sir. Amrit.
And Amrit.
Let me give a formal thank you. So Jigyasa, everybody has been praising Jigyasa, and it was really a confident, well-researched, and you spoke from your heart. That is the most important thing. To be passionate and speaking about the topic is what we really want our speakers to be. And the platform has been to showcase a lot of people who are not always on the forefront of, we see a lot of common faces, but the brilliant talent everywhere. And that's what we have intended to. I think been very, very successful because we had 350 logins today, the peak of 265. And that is absolutely a wonderful thing, because if Alim speaks, people leave, but if they, that's a different aspect. So it's brilliant. Sonia madam, always smiling, perinatal, dawn of perinatal psychiatry currently. So madam, I think Jigyasa should be encouraged more and more as a
definitely. I think we should team up. All of us should team up. I think the perinatal, I didn't focus on that. We missed that. Providing good perinatal mental health goes a long way in prevention. And we could network that area as well. And I think, yes, mother-infant bonding techniques, all these things are areas of new development. And we should have a positive approach and not a nihilistic one, definitely. Thank you so much for inspiring all of us.
Dr. Abhijit, thank you. We and Abhijit have been, work a lot together.
Thank you, sir.
Sonia and Abhijit, thank you for accepting the invitation. Sonia, convey my wishes to Anshu. But I am not seeing him anytime.
And Anshu is very busy in practice. Yesterday's OPD was closed, so he has rushed.
Don't use that term. Tell that he is very much preoccupied in being richer and richer.
No, not richer. He practices at a very low
rate. All the best in all endeavors.
He is criticized for being the most practitioner who charges the least. I hope we can continue that way.
कितना मैडम फीस कितना है आपका?
300 rupees, sir.
अलीम
So I think ours is a very, you know, Chhattisgarh is a backward.
1500 लेता है मैडम इसका.
But he's in Lucknow. We are in Raipur. We deal with lot of poor
Raipur is a
population.
better place than Lucknow, man.
Lucknow can be split to luck now. Anything you do, there is luck. Luck now.
Thank
Chaliye,
you
good
so
night.
much.
Time luck for
Thank you, everybody.
Good night.
Good night.
Good
Thank you, ma'am. Thank
for
you,
such a lovely
Jigyasa. Thank you,
Very
Abhijit
nice,
bhai.
Jigyasa.
everyone.
Everybody. Alim, bye.
Really, really good. Really wonderful.
Bye-bye.
Sir, we can close the meeting now.
Yeah, please.
Yes, we can close.
Shreya, please close the meeting.